morning, everyone. Thank you so much for joining us. I'm super excited. I love Lacey. Dr. Lacey Lemke is our provider today, our presenter today. But I'm Donna Bartlett. I am a member of the outreach team here at SunCloud Health. SunCloud Health provides integrated nuanced treatment with residential PHP, IOP, and virtual services for adults and PHP and IOP for adolescents 12 to 18, focusing on treating the whole person in Naperville, Northbrook, Lincoln Park, and Matson, which is our newest location. That is our adolescent res for girls. So super excited about that too. If you're interested in learning more about our services, I and Lori Kehoe is another contact, and our information will be included at the last slide for your reference. We are always happy to help. To make a referral, you can connect with one of us directly or call our intake number, which will be listed. We will also be following up with you after the presentation. Okay, the chat box will be on. Lacey's going to address that as well. But hey, drop in kind of like where you're from and kind of how you're doing. Okay, so I'm going to introduce Dr. Lacey Lemke. She is a licensed clinical health psychologist with specialized expertise in the treatment of eating disorders and the practice of medical and health psychology. She completed her doctoral training in clinical psychology with a primary care emphasis at the Adler School of Professional Psychology. Dr. Lemke went on to complete both her pre-doctoral clinical internship and post-doctoral fellowship through Ascension Health, shout out, we were both there, where she gained advanced training working with individuals experiencing eating disorders and self-injurious behaviors, as well as within pediatric subspecialty settings, including endocrinology, neurology, and adolescent medicine. Dr. Lemke is deeply committed to providing evidence-based, compassionate care and collaborates closely with interdisciplinary teams to ensure comprehensive treatment. Her professional mission is to support patients in achieving their fullest potential by guiding them to the most appropriate level of care and empowering them to make a meaningful, sustainable progress toward improved health and well-being. I'm so excited to introduce Dr. Lacey Lemke. Yay!
Thank you so much. Good morning, everybody. This cold, windy March morning, but I'm so excited to be with you here today to talk about our kiddos and adolescents struggling with self-injury. I think one of the biggest pieces of treating self-injury is to educate ourselves on all of the facets surrounding self-injury. And so today we are going to be specifically looking at the prevalence and trends. We're going to be working to understand the neurobiology and psychology around non-suicidal self-injury. We're going to be talking together to recognize some risk factors. I'm going to talk about some screening tools you can use in your practice. And we're going to work to identify some evidence-based interventions together, which will really help, I think, in decision making around level of care. So today we're going to be combining research findings with some of my anecdotal experiences, and hopefully you will leave here today with some practical clinical strategies to use when working within this population. So I'm going to try my best and navigate this PowerPoint. Let's see. So these you saw the learning objectives before, which I had talked to you guys about. So first and foremost, let's talk about what is non-suicidal self-injury. In the research, you're going to see this identified as an SSI. So the definition, the practical definition, is an intentional destruction of body tissue without suicidal intent. And I think that is the most important piece to take from this presentation. NSSI does not equate to suicide. We view this very separately, and we're going to talk a little bit about the relationship between suicide and NSSI, but it's important to note that they are not the same. So some examples of non-suicidal self-injury may be cutting, burning, scratching, even hitting oneself. I remember in my resident year, my first experience with self-injury was a 64-year-old sweet grandma who struggled with self-harm by means of using an iron. She would get an iron really hot and she would burn her thighs. So self-injury does not discriminate between ages or genders necessarily. So keep that in mind as we're going through this presentation. Important to note that NSSI is often used as an emotional regulation. It's used as a strategy, very much so connected with depression. The research also identifies it's connected to trauma and increasing distress. But primarily, we are working, as we work rather, to understand self-harm. The literature really points to it being a strategy used to regulate intense emotions. So, let's talk about why this matters. So, self-harm, while it's not suicide, right, or directly connected to being a suicide attempt, self-harm can predict some future risk in suicide. When we're looking at youth mental health hospitalizations, the literature has shown us that since 2009, hospitalizations related to suicide and self-injury have more than doubled. Emergency departments are reporting large increases in youth self-injury visits, and it's known as a significant predictor of potential future suicide attempts. And that's why it's so important for us to identify this early on. The typical onset ages are around 11 to 15 years of age. And we know with any disorder that early intervention really can work to improve outcome. So that's why we want to catch it early. Looking at some trends in adolescent self-harm rates, about 13 to 17% of adolescents are reporting that they're engaging in self-harm behaviors. That's a large number. And approximately 17% of adolescents are reporting at least one episode of self-injury within their lifetime. When we look at the research specific to the United States using like a multi-state sample, about 17.6% of teenagers in particular have reported utilizing NSSI. As I stated before, the behaviors typically begin between the ages of 11 and 15, and they usually peak in around mid-adolescence. So you'll see on the screen here this graph looking at the trend that we've had over the years, and you can see we had quite a significant spike in between the years of 2020 and 2022. And we are seeing the trends decrease a bit, but they are still there. You can think about what was going on in those years, right? We were right in the thick of the COVID-19 pandemic, which definitely impacted, I think, the issue of emotional regulation in our youth, which is why particularly we would see these self-harm rates increase. When we look at gender specifically, 23.8% of girls versus around 11.3% of boys are reporting NSSI in the United States. There are some data sets that actually show up to about 30% of teenage girls reporting self-injury. But it's important to note that boys may actually engage in more lethal behaviors, and boys often underreport NSSI. So important to note in your clinical practice when we're thinking about gender differences. So self-harm is appearing earlier in development. Research has indicated about 9.1% of pre-adolescent children are reporting NSSI, and that's also a large number when we're thinking about, these young kids and what they're struggling with. Some studies estimate up to about 22% of a prevalence in children under the age of 12, depending on the sample that you're looking at. And again, this just points to the importance, right, of early identification and early intervention to tackle this. So you can see this distribution on your screen where we're seeing an increased rate in those 13, 14 years, and then a bit of a trend down. So important again to reiterate, self-harm does not always equal suicidal intent, but it definitely increases the risk, right? And we know that there's a much larger amount of our kids and adolescents that are struggling with suicidal ideation. About 20% of high school students have reported serious suicidal ideation, and 9% of our youth are reporting suicide attempts. So again, while we don't want to view self-harm as equating to suicidal intent, we definitely know that those who are engaging in self-harm definitely have a significantly higher risk for suicide attempts later, especially if we don't catch that self-harm in their earlier years. So why? Why are youth engaging in self-harm? As I said before, self-harm often functions as a way to emotionally regulate. One of my favorite questions to ask patients specifically regarding any type of maladaptive behavior, whether it's eating disorder, whether it's substance use, one of my favorite questions is tell me what's good about it. It's not uncommon for those who walk into our offices or in our programs to understand, right, why their maladaptive behaviors are unhealthy. And they understand why they, quote, shouldn't be doing what they're doing, right? But very infrequently are they asked, tell me what's good about it, sell it to me, right? And I think this is important because the idea behind it is to really give us a clear picture of what's going on and what the function of the behavior is, right? I always work to normalize, especially with kids and adolescents, even adults. We don't engage in behaviors unless we're getting something out of it, right? We don't do things for no reason. And so our job as practitioners is to really understand the function of the behavior. And the function typically in this population is emotional regulation, but there's also detail behind that even, right? So some common functions you might hear when working with an individual struggling with NSSI is that it reduces their sense of overwhelm, right? They start to feel that intense emotional distress. And when they engage in the self-injury, that goes down. You might also hear our kids and teens talking about using self-injury as self-punishment or trying to regulate feelings of guilt or shame that they have. It's also not uncommon for individuals to talk about using self-harm as a way to communicate what's going on internally. So I'm feeling really distressed. I'm going to show that I'm distressed by engaging in this behavior. Patients have also talked about using NSSI as a way to almost relieve dissociation or a feeling of numbness. I've had reported many times to me, like, I don't feel anything. So when I engage in self-injury, at least I feel something, right? Or even regaining a sense of control, right? Important to note, many youth, if not all, are reporting a temporary emotional relief after they engage in the self-harm behavior. So we know that there is a cycle, a regulation cycle that's happening when our kids and our teenagers are engaging in this behavior, right? So important to note that while this behavior temporarily, relieves distress, we also see almost a reinforcement in the behavior because of that relief. So we have a trigger or a precipitating event that results in that escalation of distress. And then it's not uncommon for individuals to actually have the peak and then even start to feel some relief before they engage in self-harm. But when they do engage in self-harm, whether it's the scratching or the hitting or the cutting or burning, they get that immediate sense of relief that they're looking for. And it's also not uncommon that after that intense relief is experienced, then we start to have negative thoughts, right? Then we start to have the shame and the guilt and the secrecy builds behind it. So in essence, right, we're working to reinforce the behavior with that temporary relief, but then also have the aftermath, which is only going to promote the sense of I'm not worthy, I'm not good enough, right? And the shame that comes in after the behavior, which again promotes secrecy. So one thing that I'm a big nerd about and I love is brain function. And I think it's really important to note that there are areas of the brain that are impacted by this behavior. So I want to take a walk with you all through some neurobiology and some key brain systems that are involved with self-injury because I think that it's helpful and useful as we work to conceptualize and understand self-injury. So there are four key brain systems that are involved. We have the limbic system, particularly our amygdala, which I think we all as providers know, that's that emotional hub in the brain. Our prefrontal cortex, which is responsible for our impulse control. We also see areas of the brain related to the reward system, which involves our striatum and that dopamine pathway we'll get into in a bit. And then also our pain and endorphin systems are also involved when it comes to self-injury. So I thought it might be useful to just break these down a little bit and talk about these individually so you can get a better understanding of what's going on in the human brain when someone is going through this experience. So first, let's talk about the limbic system, particularly the amygdala. Our amygdala, as you know, again, is that emotional hub in the brain, and it's responsible for processing our fear, processing the threats around us, and it's also responsible for the emotional intensity that we feel. So when we talk about fight or flight, that's coming from our amygdala, that's coming from that limbic system. And in adolescents that have emotional dysregulation, research has shown that the amygdala is pretty hyperactive. And what that does is it results in, excuse me, the emotions that we feel or that our kids and teens are feeling, it causes them to be very overwhelming. So our youth who are engaging in self-harm often do show that heightened amygdala activation, which is giving us indication that they are feeling emotional distress very intensely, and they are also experiencing it escalating very quickly. So it's important to note that when they are presented with situations or triggers or stressful events, they're feeling it really, really hard. And then couple that with some other things that are going on in the brain, and you can see where it's a recipe for disaster. So let's talk a little bit about the prefrontal cortex. So the prefrontal cortex is responsible for emotional regulation. It helps us essentially regulate our responses that are generated by the amygdala. So imagine you have your amygdala, it's firing, it's hyperactive. Your PFC is really responsible for being almost like a braking system that's going to slow down the intense emotional reactions, right? So a teenager may feel rejected by their friends, and that emotional response is going to activate, and the prefrontal cortex is there to help them pause and think and choose a coping strategy. It's really important to note that the prefrontal cortex is not fully developed in our kids and teens. So we're already seeing a little bit of underactivation there in comparison to our older populations. The PFC is also responsible for impulse control, right? So this is what's helping our kids and our teens pause before acting. So if you think about it, this could include the ability to resist urges, right? Or to delay gratification, which we know in our younger populations is awfully hard these days. It's also responsible for considering consequences, right? And what we know is when the PFC is weaker, adolescents are typically going to act more impulsively, right? So that could definitely include engaging in behaviors like self-harm, right? The PFC is also responsible for decision making. It's going to help us evaluate risks and benefits, short-term and long-term consequences, and long-term outcomes of the behaviors that we engage in. And so when it's working appropriately, it's going to allow individuals to make more thoughtful behavior choices. But again, if we have extreme intensity coming from the amygdala, right, relying on that prefrontal cortex, you can imagine it often gets overwhelmed itself, right? The prefrontal cortex is also very vital in planning and problem solving. So it's going to support goal setting. It's going to support us being able to organize our thoughts and really think about solutions. And these abilities, as you can imagine, are critical when it comes to coping with stress, right? In adaptive ways and being able to make thoughtful choices and again, pause before we make decisions. So it's understandable from a neurological standpoint. You can see when that amygdala is hyperactive and then it's going to rely on the prefrontal cortex, we don't really have the reserve as children and adolescents to combat that necessarily, to be able to pause because that intensity is so high and our prefrontal cortex just quite isn't developed all the way yet, right? So, thinking about those components, it's also important to really keep in mind how the reward system in our brain relates to self-harm. So, self-harm may activate the brain's reward system through several different mechanisms, one of those being providing emotional relief, if you will. So, when distress is really overwhelming, that self-harm is producing rapid emotional relief, right? And the brain interprets that as being rewarding, right? As feeling good. And what that does is it creates a negative reinforcement. So in essence, we have distress that's happening, we engage in self-harm, we experience the relief, and then that behavior is reinforced because our brain recognizes that that's something that's useful, it's helpful, right? Along that same vein, we're having endorphins being released, right? Research has shown us, and we know that physical injury can actually trigger the release of endorphins. And endorphins are, I like to think of them as the brain's kind of natural opioids, right? So endorphins can reduce emotional pain. They can produce a feeling of temporary calmness. They can create almost even a mild, like euphoric or a numbing effect, right? So imagine that being coupled with the brain saying, this feels good and I like this. And then we have this next component of habit formation that can happen, right? So repeated self-harm actually is going to work to strengthen, in essence, those neural pathways in the brain area we call the striatum. The striatum is really important because its primary function is to create habits, if you will. So what's happening over time, the striatum is strengthened and it makes that behavior more automatic over time. And this is very similar to how habits are developed and even addictions can develop, right? So during adolescence, you can imagine the reward system is highly, highly sensitive, and our dopamine responses in our younger populations are much stronger. So we have our prefrontal cortex that's still developing, and there's a bit of an imbalance that happens where our adolescents may actually be more likely to engage in risk-taking behaviors or reinforcing behaviors, and that includes self-harm, right? So I want to go back to the striatum a little bit because, again, that's the part of the brain that's really helping us decide, like, is this worth doing again, right? Do I want to keep doing what I'm doing? And it sits deep within the brain, and it's a key hub in the reward system. And our reward system is what's driving like our motivation and our pleasure and learning from rewards. The striatum has two important sections, the VTA, which is called the ventral striatum, which is involved in the reward, the pleasure, the motivation, and our dorsal striatum, which is involved in habits and action selection. So you can kind of think of it like this. You have your ventral striatum, which is telling you, ooh, that felt good. Let's do it again, right? And then you have your dorsal striatum, which is creating the habit, saying, now I'm going to make this a habit. I'm going to make this an automatic response, right? So then the question becomes like, where does dopamine fit into this, right? So dopamine is the brain's kind of teaching signal, if you will. It doesn't necessarily just mean pleasure, but it tells the brain, you can imagine like something important just happened. Pay attention. Remember that, right? So dopamine is released into the brain and it travels to the striatum. Dopamine, the pathway that it goes through is that mesolimbic dopamine pathway. And so we have that teaching signal, right? Moving through the brain, going to the striatum, saying something important just happened, pay attention. And then we have the striatum that in two parts says, that feels good. I want to continue doing it. And then that dorsal area that's saying, I need to make this a habit. So the reason that I think this is all important is because it's really necessary to think about how all of these things are playing off of each other in these young brains, right? And all pointing to reinforcement of behavior and learned behaviors. The fourth area that I think is really important to hone in on again is the pain in the endorphin system and how that relates to self-harm. So in looking particularly at research, research suggests that some individuals who engage in self-harm actually may have lower baseline levels of endorphins. And as a result, when emotional distress becomes really heavy and our kids are feeling really overwhelmed, their emotional responses are going to escalate. Self-harm can occur. The physical injury that's involved in self-harm is actually triggering endorphin release, and they experience their emotional pain decrease, right? Again, that relief is reinforcing behavior. That creates a biological reinforcement loop, if you will. So we have all of these different players interacting in these young brains, which serve to continue to tell the individual to engage in these behaviors or result in them leaning almost in an automatic fashion, right, to lead into these behaviors because they've used them before and they've been effective in the past. So why not use them again, right? We know as providers, it's not sustainable because the more we engage in self-harm, our tolerance goes up, right? What used to be at an 8 out of 10 that resulted in us needing to engage in self-harm over time becomes, well, I can only withstand to a 6. Now I can only withstand to a 4 out of 10 before we continue to move further and further to where our adolescents are not able to tolerate anything at all. So that's why it's so important to target this as early as we can and to pay attention to it, right? The key takeaway here, you guys, is understanding that there's a threat and reward network dysregulation going on. And when we look at neuroimaging studies, which are really cool, it shows that there's altered connectivity between the striatal, the frontal, and the limbic regions of the brains in adolescents with an SSI. So we can understand that these areas of brain function are impacting this behavior. Self-harm can function as a biological regulation strategy, right? It temporarily relieves emotional distress through the endorphin release and through that neural reward activation. And all of these things are playing a role as we are coming in as professionals trying to encourage behavior change, okay? One thing that I find I've been really reactive to in working in the field is the notion that self-harm is simply a kid or a teen's way of getting attention. I hate the word attention anyway. Any staff that train under me or anywhere I go to work, I always encourage replacing the word attention with connection because it means the same thing, but there's a different connotation, right? Too often, I find that practitioners who are working in the field or have been working in the field for a while and they see consistent self-harm, they start to view it as a way for kids to just cry for help or get attention. And I think it's really important that we recognize even if there is a piece to needing connection and having that need met that drives self-harm behavior, there's also things that are going on in the brain that are encouraging the behavior, right? So we can't just necessarily look at it as a behavioral issue. We also need to take into consideration the cognitive piece and understand that it's going to take time to reverse that behavior or move into a different lane, move into a healthier coping strategy. All right, enough of the brain talk. I'm sorry, I just get really, really into it, and I think that it's really cool. So let's talk about some screening tools. So screening tools are really useful. And I think anytime we have a patient come into our office or into the programs that you work that are struggling with self-injury, it's really important that we get a very comprehensive look at the self-injury. We need to know frequency, we need to know duration. The CSSRS is a tool that you can use that can break down self-injury and get some good information and asks good questions. The ASQ, the Ask Suicide Screening questions, also involve self-injuries, so can be a tool for you to use. The SITB, I love. That's a structured interview specifically for self-injurious thoughts and behaviors. So we can really break down a lot of information within that structured interview. If you would like a tool that can kind of guide you through the questions to ask to make sure you get that comprehensive view. I also really enjoy the ISAS. It's the inventory of statements about self-injury. And this is cool because I always think that the more we can get from a kid or a teenager in regards to what they are thinking about their self-injury and their use of self-injury and the why behind it, the better, right? Because again, what's our goal? Our goal is to understand the function of the behavior. What is it doing for them? Because once we know that, that's where we go in as providers, right? And then the self-harm inventory is also useful. That's a very brief behavioral checklist, but important to use these tools from the get-go. When you have someone who's struggling with self-injury, we want to make sure and provide screening and understanding. Is there suicidal ideation present, right? Are they thinking that they're engaging in NSSI, perhaps as a suicide attempt? We need to be able to tease that out in case that is present. So it's always important to assess risk. But again, the research shows us that more often than not, an SSI is completely separated and it has nothing to do with suicide. Though again, it can be a predictor of future suicidal ideation or intent. So let's talk about evidence-based treatments. I would say the most researched intervention around self-injury is DBT, dialectical behavioral therapy. I love DBT. It's a huge point of focus within our SunCloud Health model. We're an integrative transdiagnostic model, so we're using multiple evidence-based treatments, but we love our DBT. So we're going to break that down in a little bit, and we're going to talk a little bit about what treatment intervention within DBT looks like and how DBT explains self-harm. And we're going to do the same with CBT because the literature also points that CBT can be very effective for self-injury as well. Lastly, we're going to talk about family-based interventions. I think all of us in the room can identify that sometimes the family dynamic is the toughest piece. It's harder to work with the family sometimes than it is with the individual themselves. And so it's really important that we bring families in when we are working with patients and really work on the family dynamic because it's not uncommon that there might be relational conflict in that area that promotes the use of self-injury. So we'll get into that in just a bit. But let's start off with DBT and self-harm. So the way that DBT understands self-harm, if you will, DBT is built on overall on what's called the biosocial theory, right? And so it says that self-harm usually develops when two things interact, okay? So first, we have a biological vulnerability, right? And what that means is that some people are born with emotional systems that are a bit more sensitive and that are a bit more reactive, and it takes them a little bit more time to return to baseline than others. Emotions feel bigger and they feel harder to manage, okay? That is coupled with the second area, which is an invalidating environment. So that can be described as when someone grows up in an environment maybe where emotions are dismissed or emotions are punished or even ignored, misunderstood, right? And they've never really learned healthy emotional regulation skills. So what happens here is we have these big emotions and we have very few coping strategies, and self-harm easily becomes a coping strategy to be used, right? When looking at the research surrounding DBT, according to DBT, people self-harm because it's a maladaptive solution to that intense emotional pain. DBT does not ascribe to self-injury as being manipulation or being attention seeking. So some common functions from a DBT lens of self-injury is, again, that emotional relief, right? That self-harm can temporarily reduce overwhelming sadness, anxiety, anger, fear, feeling something instead of numbness, like I spoke about earlier, escaping that emotional numbness or dissociation. Self-punishment, communication even, right? Like using self-harm to express distress when someone doesn't know how to ask for help, and then a way to get control. So a simplified DBT model looks at self-harm in the cycle that you see on your screen. So there's a trigger. This is from a DBT lens. So there's a trigger or precipitating event. We have emotional overwhelm combined with the lack of coping skills that leads to the self-harm. Then we experience temporary relief. Then we experience those residual negative emotions. Repeat. The key insight, if you will, into DBT that I've collected is that the behavior is reinforced because it works in the short term, right? So the goal of DBT is to replace self-harm with healthier skills that regulate emotion without causing harm. And there are four main skill areas within DBT that are used to target this. These four skills are mindfulness, right? Which is going to help people notice their emotions and notice their urges without immediately acting on them. So in this intervention, we're working to allow our kids and our teens to observe their thoughts, to be really grounded in the present, and to have non-judgmental awareness of the emotions that they're experiencing. We are really working here to create a space between urge and action. That is where mindfulness comes in from a DBT lens to address self-harm. Distress tolerance is clearly a piece within this as well. So, really working to develop distress tolerance skills to survive those intense emotional waves without the use of self-harm. So, it's not uncommon to hear about techniques using cold water, having temperature change, engaging in paced breathing, using distraction, using different self-soothing or crisis survival strategies when it comes to distress tolerance. The main goal is to get through that moment, through the wave safely without using self-harm. The third piece, emotional regulation, clearly using skills to teach how to reduce that emotional vulnerability, if you will, and manage strong feelings. So, identifying your emotions, reducing emotional vulnerability, using opposite action, building positive experiences. The goal here is to decrease that emotional intensity overall. Okay. And then lastly, working on interpersonal effectiveness, which is really working with our kids and our teens on how to ask for help and how to communicate effectively. So this is going to involve boundary setting, right? How to maintain self-respect in your relationship. And the goal with this is to essentially reduce the relationship stress that a kid or a teen is experiencing that's going to trigger the self-harm that they're experiencing, right? So DBT works to treat self-harm, you guys, as like the highest priority behavior, right? So treatment in DBT kind of follows a hierarchy. The first being we're going to address any life-threatening behaviors. We're going to address suicide, then we're going to address self-harm. Next, we're going to address any therapy interfering behaviors, right? And then after we've addressed those, we're going to look at quality of life interfering behaviors, and then we're going to work to build skills. There's a tool that's frequently used within DBT that's called a chain analysis. That's a key DBT intervention. And that's when a therapist will work to help a patient break down essentially like a self-harm episode, step by step, very methodically. So what that may look like is walking through with the patient that's in your office or in your program to understand what was the trigger, what was the thought behind it? What was the emotion? What are your body sensations? What was the urge for you in that moment? And then what was the behavior that followed, right? And then the job from a DBT lens of a therapist is to point to where skills could interrupt that chain because that's the goal, right? We want to interrupt that cycle. What makes DBT effective for self-harm is that it combines acceptance, which is really a validation of emotional pain. It also works to utilize change, right? In teaching a new coping skill. And that balance is called dialect, right? So that dialectic type of environment. And the core message of DBT is like you are doing the best you can and you need to learn new skills. Both things can be true. If you've noticed, our name, SunCloud, kind of plays off of this because you can have the sun and you can have clouds, right? Dialectics are really important within DBT and also really useful because I think especially with kids and adolescents, we got such a narrow view, right? It's really hard for our kids to see past what's right in front of them. And so it's really important that we work to kind of broaden their view and their perception of their world to understand this really important piece. Next, I would love to talk to you guys about CBT and how CBT kind of goes through and views and conceptualizes self-harm. So CBT is going to explain self-harm through that thought, emotion, behavior cycle, if you will, right? So an example, we have a situation, so maybe it's an argument with a friend, right? And then we have the thoughts that follow, like I ruin everything, no one cares about me, right? And the emotions that come up, sadness or shame or anger. And then we have the behavior, which is self-harm, right? That's being used to cope with that overwhelming emotion. What we see through a CBT lens is that behavior reduces distress and that reinforces the cycle. So next time distress occurs, again, here we go back to the neurobiology, the brain remembers, well, self-harm helped me last time, so I'm going to engage in it. And CBT works to interrupt the cycle. Much like DBT is doing, CBT kind of comes from a very similar perspective, right? So CBT views self-harm in a little bit of a different way than DBT, because CBT often identifies that there are several patterns that can increase the risk for self-harm. So those are things like negative core beliefs, right? That's a huge component of CBT. So these are those deeply held beliefs that one has about themselves. I deserve punishment. I'm unlovable. It also focuses on cognitive distortions, right? Those thinking errors that really like intensify emotional distress. So things like all or nothing thinking, mind reading, catastrophizing. These thoughts work to escalate emotional pain. And then, of course, CBT is identifying poor coping strategies, because if we don't have the tools to be successful or to manage distress, self-harm becomes that for these kids and teens. There is a self-harm reinforcement cycle within CBT too. CBT highlights that short-term reward problem, and the cycle looks like what's on your screen. So distress, negative thoughts, emotional pain, which leads to the self-harm. We have the temporary reliefs, we have the shame, and then we have more negative thoughts, right? Again, when we start to experience those negative thoughts following the event, we don't necessarily have the reserve because we're already in a depressive state, or we have these negative core beliefs that are encouraging us to feel terrible about ourselves, right? So that when we are presented with stressful events out in our community or at school, wherever it may be, we don't necessarily have the reserve to combat those from a thought perspective. So again, we see that reinforcement loop. And the goal from a CBT perspective is to break the loop. So some interventions for self-harm within CBT may be cognitive restructuring, right? Helping our patients identify and challenge those distorted thoughts, really working on the behavioral alternatives, right? Learning replacement behaviors for when those urges arise. So maybe engaging in journaling or getting up and engaging in movement physically if that's appropriate for them. Anything that they can do to release that tension safely. And then, of course, behavioral activation. We want to promote positive activities and meaningful engagement. We also want to work on problem solving, right? We really want to work to teach structured problem solving, and CBT is really good at that because it really works at breaking down problem solving in an understandable way, especially for kids and teens, in the vein of identifying a problem, brainstorming solutions, really working to weigh the options, right? And then take action. A big piece too of CBT is identifying triggers. So helping kids and teens track patterns, right? So identifying the patterns in their life that may promote the use of self-harm. So maybe that's, I'm constantly fighting with my friends. I'm constantly fighting with my mom. I'm feeling rejection, right? Understanding the triggers can help create a preventative coping plan for patients. And that leads me to the last, but also very important piece. Coming from a CBT lens, they really hone in on the safety planning. So really creating a structured safety plan that could involve identifying warning signs, coping strategies that can be useful, identifying supportive people in their life they could reach out to, reducing any access to means, right, that they may have if it's the home setting or the school setting, and different steps to take when they feel like they are in crisis. The goal here is to recognize harmful thinking patterns and regulate their emotions more effectively, right? Through a CBT lens, we are working to challenge those negative beliefs about kids and adolescents that they are telling themselves and they are experiencing that may encourage the use of these maladaptive coping strategies. One of my favorite things to use with kids and adolescents, I love to talk about sitting with the suck. Sorry for the lack of professionalism, but hey, we're talking about kids and teens, and let me tell you guys, it works. No one likes to feel uncomfortable emotions. It sucks, but I always tell my kids and teens what goes up must come what? And they'll always say down, right? Emotions are the same, right? So even if we hit a 10 and we're at a high level of emotional intensity, it will come down. You have to learn to sit with the suck. And so that can be applied to really any intervention that you choose to use. But I often find that it can be really helpful in its language that I think the kids giggle at and they understand. So lastly, let's talk about family intervention and self-harm. It's often that individuals, especially our kids and our teens, struggle with feeling misunderstood. They struggle with feeling alone. They have difficulty clearly expressing their emotions, and there's a lot of shame and disappointment. I feel like that they feel specifically in regard to their family members. They also might have high emotional conflict with their family members that actually promote self-harm. So when we bring in families, we're working to really address these issues and create a safer emotional connection for these kids and their parents, and work with parents to teach supportive responses, right? When we look at the research, it shows that when families are engaged in treatment, there can be reduced self-harm behaviors, emotional regulation can improve, we can have increased treatment adherence, right? But most importantly, there's stronger attachment and support that can happen, which is really beautiful in families. A big piece that I think is important for families to know, and family work should focus on, is really interaction patterns, because there's interaction patterns that we can see in the family system that very unintentionally reinforce distress, right? And I think sometimes that's a surprise for families when we sit with them, because there's a bit of denial, like, this is not a me thing, this is my kid's thing, right? Some examples that I'm talking about are like some invalidation, right? Which is just minimizing that emotional experience. So when a parent says, well, you're overreacting, right? That's really invalidating. Or if a child feels that they are highly criticized, or they experience a lot of pressure because they get frequent negative feedback, or they feel like there's unrealistic expectations put on them. Some family dynamics avoid difficult emotions altogether. So that's really difficult, right, to navigate. And then sometimes we have panic responses from families, which is not uncommon, especially when self-harm occurs, right? Reactions, honestly, can almost reinforce the behavior, right? So when we use family therapy, we're really working to shift these patterns toward more validation, more curiosity, and more supportive communication, right? Which is huge. So really working with families on how to learn to acknowledge emotions without judgment and build the trust and the safety within the relationship. And very importantly, teach conflict resolution and problem solving skills within the family dynamic. We also really want to work with families on how to respond to self-harm urges effectively. Specifically, I mean, I think of own examples that I've heard. So instead of saying you need to stop doing this, right? Parents could change that a bit and say, it looks like you're really overwhelmed. Like, can you help me understand what you were feeling, right? Asking those open-ended questions and coaching our families the importance of validating emotional pain and expressing concern, right? Rather than anger. So we're really working to encourage openness with families instead of the secrecy. So when you're thinking about bringing in families to patients who are struggling with self-harm, these are things that might be useful just to keep in mind. So as our last exercise this morning, you guys, meet Jake. This is my little guy, Jake. I thought it would be cool to do a little bit of just a clinical case discussion, to wrap your heads around, okay, where do I go if a patient comes into my office and is struggling with this? Like, what are some things I could do, and what would a sample treatment plan look like? So I want you guys to use your chat. I'm hoping this doesn't jack up my presentation. So I'm going to open the chat a little. I might not. I might lean into Donna to look at the chat for me. But we're going to talk. Thank you, Donna. We're going to talk about Jake. So Jake is a 14-year-old. He comes into your office or your program struggling. Well, we're going to say office, because we're going to talk about level of care. He's going to come into your office. He's struggling with self-harm behaviors by means of cutting himself. Okay. He's reporting some bullying, feeling really emotionally overwhelmed. He states to you that when he engages in cutting, it reduces his emotional pain. And he does have a history of depression, but he's never been in treatment before. Okay. So the first thing we're going to do is a risk assessment right off the bat, right? So we're going to do a suicide and self-harm assessment immediately. We're going to look at suicidal ideation, plan or intent, frequency and severity of the self-harm, access to means, all of the things that a risk assessment would include. So I'm going to give you some findings that we find about Jake. Jake has never had suicidal intent. He doesn't want to take his own life. The cutting is occurring about 1 to 2 times a week. Okay. He's using it to relieve emotional distress. He's never had suicidal attempts, never thought of taking his own life before this. And he has really supportive parents, and he's got a really good school counselor. And again, he's never even been in treatment before. So when I give you these little nuggets, what level of care do you think would be most appropriate for Jake? And Donna, I'm going to have you look at that chat and just tell me what people are saying because I'm too scared to open it up and mess up my slideshow.
Got it. Okay, so far here's what's coming in. Outpatient, outpatient counseling, outpatient. A lot of people saying outpatient. IOP, someone said. Outpatient once a week. Outpatient therapy,
Beautiful.
IOP, outside counseling. One person said PHP, mainly outpatient IOP.
Mainly outpatient. Great. So I would agree, outpatient likely, right? So we're seeing it happen 1 to 2 times a week. Given that he's never been in treatment before, he's not endorsing any suicidal ideation. This would be an appropriate candidate if you felt comfortable as a clinician, right? To start it once a week. Now, if we start to see that the self-injury is increasing, if we start to see dysfunction in other areas, if we start to see that depression going up, if we start to see any of the signs and symptoms that outpatient therapy just isn't cutting it, then we might want to bump up to a higher level of care, right? So let's talk a little bit about treatment planning. So when you guys are thinking, I want you to think about Jake. He's in your office. You've just had your initial sesh with him where you do a full intake. Granted, there's a ton of stuff missing, right? But what are just some things that you guys are thinking of? Like if you're setting up a treatment plan for a kid who's struggling with depression and with self-harm, what are some things you guys might include or think would be useful to include just for your own practice? And type those in
Harm
the chat.
reduction, someone
Yeah.
put. Exploring triggers, what precipitated his last episode.
Yes.
Validate feelings and teach coping skills. Safety planning with parents, someone wrote. Thought diary, trying to understand the why behind cutting. Safety plan to identify supports. Validation, safety planning, positive coping skills. See his ritual. For some
Yes.
kids, psychoeducation about neurochemical processes may help.
Ooh, I
Worksheets
love-
to identify triggers and stinking thinking diary cards.
Yeah.
Trigger recognition, distress tolerance building, cognitive framing, addressing automatic negative thoughts. That's one thing. Things that help him
Love
keep
it.
calm and at ease, validate his emotions, ask what it does for him. Mindfulness, behavior activation related to increasing social connection. Safety planning, identify positive outlets, exploring,
Perfect.
encouraging parents to take away all sharps.
Yes. Yes. You
Mapping
guys.
strengths and areas of joy, behavior replacement.
I love it. Yes. 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 You guys. Great. Great. So all of you thank you so much. All of you that popped in those examples, you're all spot on. Absolutely. It also just thinking about, I mean, all of this is captured in what you guys were saying. So I just broke it up so you can think like kind of conceptually. First, of course, we want to reduce the self-harm behaviors. So identifying those triggers. I'm a real stickler on making sure that, your treatment plans have, we use like quantitative things, right? So I always say like 3 of this or 5 of this. So maybe 3 coping skills you can even have in your treatment plans. I really want to see a reduction of self-harm episodes by half if you want within 8 weeks or whatever your target you feel is comfortable with. Next, of course, goal 2, we really want to focus on improving that emotional regulation. So if you're coming from a DBT lens, patient will learn DBT distress tolerance skills, will identify emotional states before escalation, and will practice mindfulness weekly. These are just examples, right? Um, why can't I click this? My computer's not working. There we go. Goals, addressing those depressive symptoms, right? We don't want to forget about those to really work on behavioral activation or changing negative thinking patterns. This is from a CBT lens, right? Improving social engagement. So I just thought it would be cool to kind of throw that out there so you kind of see some examples of goals that you might use in your own treatment planning. And then, of course, improving safety and support. So, developing a collaborative safety plan, parents securing sharp objects at home, great to whomever recommended that. Identifying trusted adults for support, right? Um, Love it. So, you guys all had fantastic recommendations. So, just important questions for clinicians that I think are really just important to leave here today with. Always focus on the function. What is the function the self-harm is serving? What are the protective factors present? That's huge, right? We want to understand who our kids and our teenagers, who are they aligning with? Who do they trust, right? Who can be there for them in the moment that they need? We always want to make sure and assess level of care, right? We want to make sure we meet patients where they are and then establish what kind of family involvement is needed. I think that's always a first line question when we're working with kids and teenagers. You got to get the family involved. With my teens, even if I've had 15-year-olds that are like, I want nothing, I'm not going to bring my family in here. I'm not going to talk to them. And I'm like, listen, you've got 3 more years at home before you're an adult and you can move out. So why don't we make it as pleasant as possible, right? Like that's how I can kind of hook, line, and sinker and get them in, because that's sometimes harder when you're working with older teens. But family involvement is really important. And if you, as the practitioner, notice that the family dynamic is such that it's not appropriate and family may be at a stuck point themselves where they're unable to meet the needs of your patient that's sitting in front of you, then establish chosen family, right? Like let's bring people into treatment who can be there for you and can continue to enhance your growth. So, you guys, I took us all the way almost to 12. Thank you guys so much for your time. Before you leave, I know Donna has some fun things to chat about, so I
Well,
will.
and you have some questions too. Can I go through
Oh,
some, Lacey?
yes,
Okay.
yes.
So
I'm just
here's
gonna
a
pop up
couple
this
from,
slide.
okay, thank you. Um,
You're welcome.
Yeah, so I'll like just say really quickly about the slide. Our next CEU presentation is with Katrina Gainey. Exciting. So she'll talk about reading between the lines, supporting subtle dysregulation and neurodivergent children. Sorry. Okay. So please join us if you're not already registered. Love to have you. And then obviously that's my slide. Always happy to help connect, listen, support, whatever I can do, as well as Lori Kehoe. Okay, so here are some questions, Lacey. Does teaching psychoeducation to teens correlate with decreasing impulsive behavior and minimizing risk of self-harm? i.e.,
It's a
teaching
great
about
question.
wise man or the upstairs brain, downstairs brain, building self-awareness of how the brain works. That was the question.
Absolutely. Absolutely. But I think most important that we have to keep in mind is we should couple that, right? Couple that with skills. So we can give the psychoeducation is extremely useful. I also noticed somebody said some psychoeducation on the neurology behind it. Love that because I think even in our younger populations, it can help them understand that there's something else going on, right, in their brain that's contributing, which can be really relieving. But to answer your question, psychoeducation is fantastic. I'm not really sure. I'm not sure on the literature behind using psychoeducation solely as a way to decrease that, but I certainly think coupling it with skill work, absolutely. That's a good question.
And a couple of people asked about the screening tools. Are they available free or online that you talked about?
That's a great question too. So a couple of them are free. What I'm going to do, we have everybody's emails, right?
Right. We'll send out the slides and everything after. So if you want to give me something, Lacey, I'll attach
I
it to
will.
it. Okay.
I will. You know what I'll do? I'll go through and see which ones are free so you can make sure and have those. Yeah.
Perfect. And then someone did say, do you recommend a specific screening tool for a shy teenager that struggles to open up?
I would do, I love the structured interview because I think it really guides them to being more open. Um, you know, or the looking at the statements of self-injury, that's a really good one too, the ISAS. So yes, I think it's really that's a tough one too. I think,
Mhm.
first establish rapport and do your best, but I do love the structured interview, only because it's does a thorough job at asking the questions you need to ask. And sometimes when we're sitting in front of a patient who's giving us nothing, our minds go blank. We're like, where in the heck do I go from here? So having that structured interview can be really helpful.
That's awesome. Earlier in there, someone said, okay, do you have recommendations? And we all know, right? the mental health screening, like the stuff that's happening next year in schools, right?
Yeah.
So, do you have any recommendations for a mental health screening tool that's student administered and will be approved by the SB 1560 bill passing?
Oh, my friend, I don't
I know.
know.
That's what I'm like. I don't know yet. If we
I
find
don't
out, I'll
know.
circle back because that's something that we were talking about, and I'm in schools all the time. And so if I have any information, Emily, I will give it to you for
Yeah,
sure.
I'm sorry, Emily. I don't know off the top of my head, but Donna would be a good resource. So,
And then how do we
yeah.
manage the confidentiality? Oh yeah. So this question, how do we manage the confidentiality with a minor and the parents when self-harming is happening? And what can we do if we see that the environment is not considerate and they do not take seriously what's happening with the kids? Sometimes culture, right, are different. And any suggestions on that?
Two very important questions. Okay, first off, so I think it really depends who you ask on confidentiality, right? Because you
Mhm.
are going to have some clinicians that have zero tolerance and say, I'm telling your parents, right?
Mhm.
So some factors that I keep in mind, age, right? If they're a young tot, no question, I'm telling parents, no question, right? Now, if I have a 16 or a 15, even a 14, maybe 13, I don't know, year old, it depends on the self-injury. It depends on the frequency, the intensity of it, right? If they're scratching themselves, I might keep it tight-lipped as we work on it, right? If I see it getting pretty severe, I might bring in parents. But here's the thing that I find to be really effective, and I've done this many, many times, so anecdotally, it works. It can work, I should say. I really work to build rapport with the kid and really empower the kid to tell their parent. I don't ever want to tell parents anything, frankly. With the littles, it's different, but when we're talking about teens, I don't like to tell parents anything. I encourage the teen to do it. And then I say, I'm going to be sitting right there next to you. Like, you're not doing it by yourself. I'm right there. We're going to be together, but I want you to disclose this. I want you to talk to your parents about it. So that's kind of how I phrase it. If you got to weigh the severity and the intensity, which that's not an answer to your question. And I get that that's extremely annoying. But it really depends again, because there's a difference, right? There's a difference if someone is burning themselves incessantly above the kneecap and parents can't see it and they're having to doctor it themselves and there's a ritual around it, right? Like that's intense versus a 12-year-old who says, "Well, I scratch my leg whenever I'm feeling anxious." So you
Mhm.
really have to weigh it. I don't view that there's like a one size fits all. Um, so yeah, I'm sorry. But confidentiality is a big piece. And especially with your teens, you're going to lose it all. If you tell parents anything that they don't want you to tell them, you're going to lose it. You're going to just lose the trust. And I'm really not willing to ever lose that unless there's a risk of an imminent risk of safety. So I think it's more conversations about how can we let parents know. You can even say like, I have to talk to your mom or your dad about this. How do you want me to do it? And I think getting them on board. So I hope that that answers your question a bit. And then second question for family systems that are just not great? It's a really tough question. And I think I'm of the mindset that we keep trying. Like we never stop trying. But if we reach a point where we know that we're stuck and we know that it's not going to go anywhere, I think really working, it depends on the age of your patient too, right? Because you're not going to be having this conversation with a 10-year-old. But if you have a patient who's like 16, 17, we can have that conversation of this may be where mom and dad is at right now. Right? Like this may be, and those are hard conversations to have, but sometimes they're needed. And so you can weigh that in your clinical practice. I think looking for supports at schools, huge because they spend most of their time at school. And then as we prep for summer, when they're going to be at home more, setting up some structured things for them to do. How can they remain connected with supports from school? Are there activities? Are there camps? Are there things with the park district where they live that they can? So really working to get that sense of connection elsewhere if they're really just not going to get it at home.
Yeah. Couple more. I know we're over a couple more just because I want to kind of hit some of these. Hey, Claudia Kelly, good to see you here. She says, does SunCloud have specific IOP, PHP programming for self-harm?
We absolutely do. We don't have tracks here. We don't do that. But we program all of our patients together and we see self-injury a lot. We do. And we
Yeah.
view self-injury as a symptom of depression or a symptom of anxiety. Um, we're very equipped here to manage it, and we absolutely do. Yes,
Yeah, we
IOP,
treat
and
the
we
whole
have
person,
PhDs.
right? We treat the whole individual. And so, Claudia, hey, shout out to me if you need some help. I am happy to help answer any questions further or navigate someone kind of into treatment. You know me. Okay, do you have any content you can share to help parents who are blaming the teen and who believe that therapy is part of the reason that they're not getting better?
Yeah, recommend they have a therapist. No, I'm just kidding. Um,
That's a
um,
therapist too.
Oh, that's tough. That's really tough. It depends on the style that you have, right? If I were in that situation, I would have a conversation with the parent alone, without the patient present, and have a real conversation that comes from a place of curiosity, right? That's how we always want to come whenever we're challenging, especially parents, because you guys know you have to align with parents or they're not going to let you work with their kid, right? And so that alignment, and I'm not saying 100% aligned, but it's very important that you're on the same page, and it's also better for the kid in general, right? They need to feel like they have a good cohesive support around them, even though sometimes we may be faced with situations like this where we know parents don't appreciate what we do or blame us, whatever. So I would have a conversation with the parent, and I would again come at it from a very curious perspective, and just being thoughtful and asking lots of questions. And as a clinician, really working to be open with what you're working on. Should the kid be okay with that? But also just really making sure to outline why you do what you do and what your purpose is, right? But I think a one-on-one conversation is important, and to leave the kid out of it at that point.
Okay, just to remind everyone, yes, you will get CEs. You'll get an email with the survey, and um, then we'll send out the slides, and Lacey will give me a little something that has maybe some
Yes.
more screeners. And I think I got most of the ones out of chat. I'm so sorry, you guys, if I didn't get to you. But again, feel free to reach out to me. Obviously, Lacey, Dr. Lemke is amazing.
Yeah, that's my cell phone, you guys. Clearly, I have no boundaries. So take it, save it. You guys can reach out to me with anything. All the people reach out to me all the time and just ask questions. I'm more than happy to be a resource for you.
Yeah, we're here if you guys need anything. And obviously, like it can be about getting into treatment or just questions about things that like
Yeah.
you're struggling with. That's what we're here for. Okay,
Yep.
thank you so much again, Dr. Lemke, for sharing your
Yes. Thank you,
wisdom.
guys.
Thanks everybody for coming. Happy Friday. Looks like it's not as windy out today now, so hopefully enjoy the rest of your day.